Good evening, everyone. Welcome. Thank you so much for joining us for this virtual UMiami Health Talk. Meet the experts, Advanced Heart Surgery at UHealth. I'm health journalist Ileana Bravo, your moderator for this evening's webinar, which is presented by UHealth's Cardiac and Vascular Program. UHealth's cardiovascular experts pioneer and advance the latest heart procedures. The cardiac surgery team provides comprehensive expertise across the full spectrum of cardiac procedures, including coronary artery surgery, heart valve repair and replacement, complex aortic surgery, and, of course, minimally invasive approaches. UHealth is home to the only mitral valve repair center of excellence in South Florida and has earned the highest 3-star rating for aortic valve and mitral valve surgery from the Society of Thoracic Surgeons. So we invite you to learn more about our cardiac surgery program. Visit umiamihealth.org/heart surgery. And to schedule consultations, call 305-689-2784. No worries, we're going to repeat that information again so you can get it at the end and know how to contact us. But tonight, our panel of experts are going to discuss heart surgery innovations and advanced procedures available at UHealth. They include the latest advances in minimally invasive valve surgery and heart procedures, our new aortic valve surgery program offering a comprehensive range of advanced surgical interventions, how our heart team approach ensures the best option for every patient, and innovations shaping the future of cardiac surgery at UHealth. Now, at the end of the presentation, there's going to be a Q&A session, questions and answers, which is a unique opportunity for you to ask direct questions of our experts. It's a great opportunity. So use the Q&A feature at the bottom of your Zoom screen. Take a look at your particular computer, and that's where you're going to enter your questions, and we'll prep them for our experts. So now it's my pleasure to introduce our speakers. Dr. Juan Pablo Umaña, an internationally recognized cardiovascular surgeon known for his pioneering work in aortic and mitral valve repair. Board certified in surgery and thoracic surgery, Dr. Umaña trained at Columbia Presbyterian Medical Center and Stanford University School of Medicine. He established the leading aortic and mitral valve repair program in Latin America and co-invented the MitraClip, the first transcatheter mitral valve repair device. With more than 150 scientific publications, Dr. Umaña continues to be a global leader in advancing cardiovascular surgery. Speaking with him tonight is Dr. Ciro Amodio, a cardiothoracic surgeon and associate professor of cardiothoracic surgery at the University of Miami. He specializes in complex aortic disease and advanced cardiac surgery. Trained in Italy, the Netherlands, and the UK, and previously at the Cleveland Clinic, Ohio, where he was provided mentorship under Dr. Eric Rosselli. Dr. Amodio is an expert in open, hybrid, and endovascular aortic repair, valve surgery, and high-risk reoperations. He has authored numerous publications and was awarded the 2025 Carlson Mooley Award for Excellence in Cardiothoracic Surgery. So, gentlemen, I ask you to both open your microphones, make sure that we are ready to go, and they are going to present simultaneously and together in a team approach. So what a treat for the audience tonight. Gentlemen, take it away.
Ileana, thank you very much. It's a real pleasure to be here. I see there we have a staggering number of people attending, which is wonderful here. Previous and future patients, I'm sure, and you said it. I think that one of the features that are up and coming at is an integrated patient-centered teamwork, and we'll go over this in a minute. Dr. Amodio and I'll share my screen, and after that, I think that we will continue to talk in tandem. But so when we talk about innovation, I think the first thing we need to talk about or focus on is the fact that we sometimes think that in the pursuit of excellence, we don't really need to care about the patient at the center of it all. That if you offer, outstanding specialists in each one of the subspecialties, and each one of them sees the patient independently, you will eventually get an outstanding outcome or result. And the what what's very important to see is this quote from Steve Jobs' biography. Uh, I, am getting a message that are you seeing my full screen or not?
No, so we're seeing it in this presenter mode, so we see your notes on the side and all that. So I think you have to try and present normally. I wasn't going to
There you
interrupt.
go.
There you are. Thank
Is
you
that
for
better? Perfect.
that's it.
Okay.
That's fine.
So Steve Jobs said it when he was being treated for his pancreatic cancer, uh, that he suddenly realized that he was getting treated. He was getting an absolutely fantastic treatment at Stanford, but it was fragmented. He was getting the best of the world, but nobody was coordinating that care. And that's something he would have never permitted at Apple. So, being Steve Jobs, he convened everybody at his home and got him sitting around a table and working together. And that is exactly the kind of disconnect that we oftentimes see, and one that we in medicine are very used to seeing. Whereas what we need to do is work as a team, truly almost as a pit crew around the patient, where everybody's concentrating on the patient alone and making sure that that way the outcomes are absolutely outstanding. So the first innovation that we're applying in heart surgery at is a real heart team patient-centered approach that will lead to optimization of outcomes through teamwork, concentrating on two things: improving the quality of life, but more importantly, restoring life expectancy through timely intervention and application of the latest techniques. And that is very, very important. But the thing that we need to keep repeating and concentrating on is that we will concentrate on offering the right operation at the right time through the right approach. And I think today, and as you mentioned, Liliana, we're going to be concentrating mostly on valve surgery and aortic and complex aortic surgery. And when we look at the burden of valvular heart disease, and this is a paper that was a landmark paper published already several years ago, but you can see that over 55 in orange, mitral valve disease really shoots up. In other words, in patients over 65, you start seeing a staggering increase in the incidence of mitral valve disease. In green, you see aortic valve disease, and that happens a little bit later. After 65 is when you start seeing an increase, a significant increase in the incidence of aortic valve disease, and it's usually stenosis. But that increase that you see from 45 to 65, it's insufficiency, meaning the valve has a leakage, it doesn't close properly, and those valves offer an enormous opportunity for new techniques to be applied, techniques that restore life expectancy and that improve quality of life. And Dr. Amudio will go over those in a minute. So if we start by talking about innovations in mitral valve surgery, mitral valve repair, we know already is the gold standard. It is the one operation that has been proven to restore normal life expectancy. And minimally invasive mitral valve repair is by all means the way to go. It is the standard of care at the University of Miami. It's the reason why we, together with our outcomes, the reason why we are, as you mentioned, Liliana, the only mitral valve repair center of excellence in South Florida. And as a tail off to that is minimally invasive mitral valve replacement for those patients who have valves that cannot be repaired, usually valves that are either calcified or that have a degenerative component to them. And then we have to invariably talk about micro-invasive techniques. And micro-invasive techniques are those that refer to transcatheter interventions. In other words, you don't even have to make an incision. You're going through the groin, through the vein, across the heart to fix the valve. And that's what the MitraClip does, which is a transcatheter mitral valve repair technique that we have available to us today. It's called the TEER, which is a transcatheter end-to-end repair. and transcatheter mitral valve replacement, which is something that we're starting to apply at the University of Miami as well. Minimally invasive mitral valve repair, as we said, it restores life expectancy. And through a minimally invasive approach, it leads to less pain, a shorter hospital stay, and faster return to normal activities when you're treating patients with mitral valve insufficiency. Now, when you look at the numbers and when you look at what is happening in the universe of mitral valve repair, you see in orange the phenomenal growth in transcatheter edge-to-edge repair, which is the TEER, the mitral clip, with a slight decline in the number of surgical mitral valve repairs. And even though it has an indication and it has a place, let me remind you that we're here to offer the right operation at the right time and through the right approach. And the only thing that allows us to guarantee that is that heart team approach. Now, as we move into aortic valve disease, this is the aortic valve disease universe, and this is just a bunch of numbers. But what I want you to look at is the green line. The green line is a transcatheter aortic valve replacement, or TAVR, or TAVI. Many of you have heard about it. Probably some of you might have had it. You can see that the numbers are staggering. Over 100,000 performed in 2023 versus 63,000 of all other surgical aortic valve replacements. The only thing that has grown the only surgery that has grown over the last few years is the replacement of the aortic roots, which includes the Bentel procedure or the Ross procedure. And that is the other topic that we're going to be talking about, because it's the Ross procedure and the Bentel procedure, as well as aortic valve repair, the three that cannot be done transcatheter and the ones that have proven to restore life expectancy. And we will go over that in a minute. This is very important when you're considering or thinking of TAVR or TAVI. If you're under 65, the risk of mortality over the following 3 to 5 years after a TAVR is significantly higher than after a surgical aortic valve replacement. And the reason why I bring this up is because at the University of Miami, over the last 5 years, the mortality for surgical aortic valve replacement in patients of all ages has been zero. Whereas the mortality historically for TAVR, not at but reported countrywide, stands at around 2.1%. So this is something that I keep repeating, because as you will see in a minute, one of the fastest growing operations today in cardiac surgery is explantation of transcatheter aortic valves. As you can imagine, with that exponential growth in the number of implants, the number of explants has to increase as well. So we have to be very wary of that and know what the results are at the center that you're seeking care. So again, very important to have a team deciding which one is the right operation, at what time, and through which approach. I'm going to hand it over to Dr. Amodio now to start talking about advances in aortic valve surgery and give you an idea of what we're doing and how we're changing the phase of aortic valve surgery in Florida out of UM. Dr. Amodio.
Thank you, Dr. Romana, and thank you, Ileana, for the introduction. Yeah, I love the topic of the advances and what is new about the here at how to address the aortic valve surgery. As you can see from the next slide, aortic valve surgery is a very present disease in the United States, accounting for more than 64% of the total number of valvular disease in the country, and a very growing disease, especially there is a cutoff around 45, 55 years of age. Aortic valve stenosis really peaks in consideration of all the other gen groups in regards to all the other valvular abnormalities. But what it really is aortic valve stenosis. We can see here. Normally, you see the aortic valve is like the exit door of the left ventricle in this tri-leaflet configuration, very pliable leaflets, and this is the way it should normally work, given a good area, more than 2 square centimeters. But in these kind of conditions, calcium deposits over the valve, and with time, this stenosis can become very severe. And this is an intraoperative image of how the aortic valve from a beautiful 3-leaflet valve can become severely stenotic and narrowed. And this can start affecting you, the way you're feeling, giving you a symptom, shortness of breath, dyspnea, and your heart muscle starts to suffer as well. So normally the conventional way that we've been approaching for years to aortic valve stenosis is the aortic valve replacement. And there has always been this arm wrestling between the two different kinds of valves, biological valve and mechanical valves. Here at the University of Miami, we have the newest on the market, Inspiris Resilient, which is a bovine pericardial valve that is treated in a way that the leaflet can last you as long as possible, and it's preserved in a way that the valve calcificates over a very long period of time, and is also a valve that is meant to be broken and can accommodate a TAVR valve in the future, given its struts. On the other side, instead, we have the Onyx valve, which is a newer on the market as well, can give you a lower INR range and can kind of lower the risk of bleeding that all mechanical prostheses carry. The risk of having trauma if you're doing physical activity, or unfortunately if you fall, or even having a brain hemorrhage. But overall, whenever we consider an aortic valve replacement, especially in the young adults, whatever valve you choose, whether it is a biological valve or a mechanical valve, this will carry you a risk of an increased mortality, which is between 26 and 30% if you are around your 50s, and in the 55 to 64 span a year of age, it's over 30% at 15 years. Whether this happens because of your risk of reoperation or overall mortality can increase. This is particularly true when we look at the numbers that are after your operation. At 10 years, 1 in 5 patients gets reoperated. 82% of people are either dead or reoperated after an aortic valve replacement. So we've been thinking about ways of lower the risk of reoperations, and one of the ways that has been really helped in cardiac surgery is the advent of TAVR and the advent of valve-in-valve, meaning putting in a previous biological prosthesis, putting a new valve passing through the groins has really significantly reduced the risk of mortality from reoperations. But we have to think about the fact that when we start putting a valve inside another valve, this can carry a risk of having a residual high gradient, meaning that you are having, again, symptoms that are similar to the ones of the aortic stenosis, of your initial diagnosis. So really, valve-in-valve sometimes is not the solution, but can carry the risk of having a Matryoshka effect, meaning a valve that it's too narrow. And then the other thing, as Dr. Romana was saying, what the cardiac surgeon is being faced now is to have the skills of being able to remove now this TAVR, this stented valve that is being implanted and is in the root and is embedded in your aortic wall, and that carries the risk of passing from an aortic valve replacement to a complete, more difficult operation when it gets so embedded in the aortic wall that taking it out can carry the risk. And this is what we're offering at the University of Miami, a team that is not only expert in dealing with the aortic valve, but also with the aorta in general, in the aortic root. And so you can carefully remove the TAVR valve without damaging the root, or in case the valve is too embedded, it can proceed with a replacement of the root itself.
And that's exactly what we're concentrating on, right? Dr. Amadio, we're trying to provide a high level of complex care, which we believe Florida is in very in need of. South Florida and Miami, and the University of Miami is here to provide that. And I think the real message is that conventional AVR in the young leads to an excess in long-term mortality. So the exact opposite to what we're here to do, which is restoring expectancy or expected survival in younger patients. So why don't you tell us a little bit about what we're bringing to the table in terms of evolving surgical solutions?
We're thinking about a more personalized approach to aortic valve disease in general. So looking at the patient details and the patient studies, whether if the patient has an aortic valve insufficiency with a valve that you can see here in these images, whether your valve is bicuspid, meaning you're born with a very frequent congenital aortic valve disease, which is the bicuspid valve, meaning you have only 2 leaflets instead of 3. Normally, this valve, if not calcified severely, they offer a lot of tissue for us to work with and to try to repair and cut and sew and try to find a way to make this valve work and competent again. So to have a valve that is repaired and is not insufficient anymore, it can last you way longer than a prosthesis. And this is also true with tricuspid valves, as you can see lower down. We can work also around the valve, correcting the aorta, correcting the sinotubular junction, and looking at the root in its complexity. There are multiple studies that have shown that actually aortic valve repair significantly improves your postoperative outcomes when you have an aortic regurgitation. If you look at the central image here, you can see that when a valve is replaced, no matter the kind, your mortality overall is higher. Whereas when you repair the valve, the line that you can see at the top, the survival, it's very similar to the general population who didn't have an aortic valve replacement at all. So it really restores you. It's the only, when feasible, should be the operation of choice, should be the operation that you should go for. And here you can see freedom from reoperation and any cardiovascular events. When you're young, and talking about young adults, and here in Florida, we have a flourishing number. What we're offering here at the university, especially in cases of bicuspid valve that are stenotic or tricuspid valve that are stenotic, which are meaning with a root that is not dilated, we can offer a Ross procedure. The Ross procedure is a very well-known operation. There are studies that span for more than 20 years. And it's an operation that has an excellent result if done by the right people with the right experience. We take your own valve, your own pulmonic valve with the whole root, and we move it, we replace it in the position of the aortic valve. So we give you an auto transplant. It's called pulmonary autograft. And then we restore the continuity of your pulmonic root with a valve, with a human valve donor. This is this valve fits you perfectly and is the only valve that can restore the long-term viability of your aortic root, being this a living valve, a living tissue that your own heart has donated from the pulmonic position to the aortic position. As you can see over studies, the Ross procedure really restores your survival where compared to any other valvular disease, and carries a very low risk of reoperation, with the only indication that you really control your blood pressure for at least the first year, because your pulmonic valve has to adapt to the new aortic pressures. So we don't only consider the aortic root itself, but we are thinking about a bespoke approach to the aortic valve and the way the aortic valve sits inside the aorta. So we look at the aorta and we look at the relationship between the aortic valve and the ascending aorta and the whole aorta itself. As you can see from this picture, And the next, there are the very related flow dynamics between between a heavy heartbeat and the flow of blood that gets ejected from the ventricle to the aorta, and the way whether you have a tricuspid valve or you have a bicuspid valve, this can change a lot in how the aortic wall gets stressed because of the turbulence of flow. And this is a very beautiful image done with an MRI, for the MRI, to show you the flow dynamics inside the aortic root.
Which is,
yeah.
If I may, Dr. Amodio, these images can be obtained at only a very few centers in the U.S. and the world, and we're one of them, right? We have one of the most advanced cardiac imaging centers, not only in Florida but in the United States. So we're fortunate enough that we can obtain these images and do these flow studies on these aortic patients, not only before the surgery but after the surgery.
Exactly. So this kind of links the aortic valve disease to what is called a bicuspid valve orthopathy, or in general an orthopathy that can lead to an aortic aneurysm. Aortic aneurysms are another very important and very common disease. There have been many studies, and in centers of excellence as ours, we should operate any aortic aneurysm that is above 5. But as I said before, we kind of tailored on the patient. So we look, first of all, at the relationship between the aortic size and the body habitus of the patient, his height, his body surface area, to kind of distinguish when an aorta is dilated enough for it to go for surgery, because the main risk is either rupture or dissection, aortic dissection of your root. And this is particularly true when we look at bicuspid valve, or if we get into the territory of connective tissue disorders, meaning the diseases that of the connective tissue or the fibrillin, or all the components of the connective tissue that can affect not only your aorta, but in syndromes like the Marfan syndrome, the Ehlers-Danlos, and the Delois-Dietz, multiple organs are involved. And these are kind of trigger for us to, by looking at you, by examining you in our clinic, we can then guide you to a genetic testing that really can change your life expectancy, because we can detect very early any aortic problem, and we could treat it before it becomes, because it leads you to a complication. The main treatment that we're doing is, especially in this kind of patients, or in patients that have AI with a dilated root, is the David procedure. The David procedure is something that we have been offering here. Is a very well-known operation, and it really saves your valve, and it reimplants it in a graft with which we replace the aorta, and we reimplant your coronary arteries. Here you can see how beautifully the valve sits inside the graft, and will last you longer than a bioprosthesis. And in the same time, we are able to tackle the problem of the aortic valve, the root, and the aneurysm. We don't stop at the aortic root. We look at the whole aorta. Also, in our approach is a team approach together with the vascular surgeon. We are able to treat you from the root, the ascending, the aortic arch, and down to the descending thoracic. We bring the experience of multiple center. I was in Bologna, one of the pioneer centers for the frozen elephant trunk, and we both were in Cleveland Clinic, where the B-Safer has been invented. And these are techniques that we can offer to the patients to not only treat in one single operation a problem from the aortic root, the aortic arch, and the descending thoracic, avoiding the patient another open operation, and most likely creating either a landing zone for a future TEVR, meaning an endovascular approach, or really reducing the risk of having a full open thoracoabdominal. This kind of operation are done with a great team that we have here at the University of Miami, with perfusionists that are capable of working with us in these cases, and a great anesthesia team. we are able to offer these cases especially in aneurysm or in aortic dissection that have been previously treated in other centers that have offered you a partial repair, and now we can do a reoperation and fix the entire aorta for you.
And this is something that can only be done when you have a truly outstanding multidisciplinary team, like the one we have with the specialists and the support staff that you just mentioned, Dr. Amarillo. So what is the future? The future is a heart team approach, and that heart team needs a place to function, and that place are hybrid operating rooms. And we at the University of Miami are currently building probably the most modern hybrid room in the region, in order to be able to offer not only open procedures and not only transcatheter procedures, but the combination of both, involving, as Dr. Amarillo said, vascular surgeons, interventional cardiologists, echocardiographers, imaging cardiologists, cardiac surgeons, the whole gamut of subspecialists that can contribute to optimize outcomes on every single one of our patients. In other words, concentrating on the patient in a hybrid room is where it all comes together. In the future, what we will be offering, and that is a very near future, are all the latest technologies through clinical trials as we expand our expertise to every single one of the patients that want to seek it and that need it at the University of Miami. Thank you very much.
Dr. Umania, Dr. Amarillo, a master class. I have rarely seen the audience speechless, only a couple of questions, because it was so thorough and comprehensive, your explanation. So we've started the Q&A session, so let's get into it, because there are a few questions that they had sent ahead of time. So let's talk about what has changed in the last 5 years, because you've sort of taken us to the future just with this explanation alone. What has changed in these 5, even 10 years to replace an artificial mitral valve once it fails? Where are we?
So, if you allow me to take that question, if you have an artificial mitral valve today, if you didn't have your mitral valve repaired, we have the option of replacing it through a transcatheter approach, which of course means you don't need another open operation. Now, it obviously depends on your age, depends on your overall health status, because at times, and one of the things that we emphasized was the fact that we offer the right operation at the right time through the right approach, correct? So yes, we can offer a transcatheter replacement of that mitral, of that degenerator or failing mitral valve, but we can also offer a minimally invasive approach to replace it in patients who are young and who warrant another operation, so that the transcatheter approach comes at a later date. And the reason is that Matryoshka effect that Dr. Amarillo mentioned. When you have a mitral valve and put a valve inside that valve, the second valve is going to be smaller. And if that valve fails, if you're at the second operation, you're, let's say, 50. At 65, you will need another one. So that means that you get another one that's going to be smaller, and the next one is going to be smaller, and that is basically a snowball effect that will lead.
I'm actually answering one of the question from the audience is if the valve can be replaced with surgery instead of getting another TAVR. And done in the right centers, this reoperation for an aortic valve replacement is a very low mortality operation that can be done safely. And especially if your initial valve was a small valve and you're in a young age, in a good shape, I would really advise you to have a reoperation that is a low-risk operation and can accommodate you a same size or even a bigger size valve, in case of we can do a root enlargement, and this can really give you a bigger span, many more years than having another valve inside.
So let's talk about this as well. How about the tricuspid valve? Do you do that valve as well? And let's talk about minimally invasive, because that's going to get everyone's attention out there. Can I do it with the little holes without having a major?
Yeah, we offer from maximal invasive to minimal invasive, from sternal sparing and minimal approach, especially for the tricuspid valve. It's an operation that can absolutely be done via mini lateral thoracotomy, and it's most of the time a valve that can be repaired. It's a very easy approach that we very standard do, and with a peripheral cannulation, and we approach to that valve as well as the mitral valve as well as the aortic valve. Offered through minimally invasive approaches.
Liana, one of the questions live, and if I may take this one, says
Please.
that somebody asked if the Recilia valve can be replaced by a surgery instead of TAVR, and the answer is absolutely yes. We can, and we can offer results that are unparalleled. I think we can offer a risk, a surgical risk at the University of Miami that is very close to the surgical risk of the original operation. That is one of the things that differentiates us.
Mm-hmm. Mm-hmm. Now here's a question, since we're going live now, right? Dr. Manya, this person asks, at age 85 to 90, what's the best procedure for moderate to severe aortic stenosis?
So it depends where you are. In Florida, I think we both agree. It's amazing how well an 85 to 90-year-old is. So it depends on level of activity. It depends on symptoms. Depends on vitality. So moderate to severe asymptomatic. There are additional tests that can be done, like left ventricular myocardial work is one of the things that has been shown to predict the risk of mortality. But if asymptomatic at 90 with a moderate aortic stenosis, what I tell my patients all the time is I treat my patients as if they were my own family, and I don't think I would send my mother or my father for a TAVR or a SAVR at 90 with moderate aortic stenosis. I think that can be carefully watched without a problem.
Yeah. Now, once your aortic valve regurgitation is severe, what's the time period that you say now the replacement surgery of the valve is needed?
Aortic valve insufficiency and aortic valve stenosis are two different diseases. And once your symptoms start for an aortic valve stenosis, we know that the mortality increases significantly. So you should get, depending also on your gradients on the valve, you should seek attention of a surgeon urgently. But this is also true with the aortic insufficiency, because sometimes the patient accommodates better, the ventricle accommodates to this regurgitation more, but is a more silent killer, because then the aortic valve insufficiency then starts chewing muscle and your ventricle gets dilated up to a point that your ejection fraction, meaning the strength of your heart, gets too low. And that's also something that I think should be taken seriously.
Aortic insufficiency, Liana, is as Dr. Amodio just said, is a silent killer, a little bit like mitral insufficiency or mitral regurgitation, and it needs to be paid attention to. When you have severe aortic insufficiency and your ejection fraction falls below 55%, that is an indication for surgery. If you have symptoms, that is an indication for surgery, of course. And patients and people tend to mask or deny symptoms because we accommodate, and we start looking for excuses. I'm getting older. I don't know. I gained some weight. I'm too busy, so that's why I'm not really exercising that much. And what about the stairs? Well, I take the elevator because it's faster. So those are things you have to pay attention to. And one of the things that goes hand in hand with that is dilatation of the ascending aorta, and there is a question in the chat. Somebody was 69 with
Yeah.
bicuspid valve and an enlarged aortic root at 4 centimeters. That is a case that we can repair. Bicuspid aortic valves, as Dr. Amodio showed, are valves that can be very easily repaired. As a matter of fact, bicuspid aortic valves were made to be repaired when they're leaking. And if the root is 4 centimeters or larger, the best way to repair the valve is through a David operation, reimplanting that bicuspid aortic valve inside a graft. And that will, get you a better long-term result, less complications long-term, and restore your life expectancy. So now it depends on the degree of leakage and aortic insufficiency, but something that needs to be looked at for sure.
And the 69-year-old asks, is it something that needs to be addressed ASAP?
It should be, yes. Meaning the surgery doesn't need to be ASAP, but seen by a specialist or a surgeon, yes, to determine whether there is severe aortic insufficiency, what the diameter of the aorta is, and how it's impacting the function of the valve.
Yeah. Dr. Umano, Dr. Amodio, take a look at the question that just came over, and it's from one of your peers, an MD, in the chat. What is the natural course of the pulmonic valve autograft now in the aortic position with the Ross procedure? Does the milieu of the patient result in its becoming calcified with time? What's the status of any drugs or intervention to affect the rapidity of calcification of either native or autografted valves?
That is fantastic. That's a fantastic question, Dr. Almeida. You want to take it?
Yeah, sure. So early calcification is quite uncommon. Early meaning less than 5 years. So with these homografts, we look at least 10, 15 years or more. And you're absolutely right. There is a risk of calcification. So that's why there have been multiple studies that have been done. And the kind of homografts that we are using here are decellularized homografts. So the homografts that have been treated in order to reduce the risk of having calcifications. And this has been done by the way the homograft has been treated before being cryopreserved. At the same time, this calcification happens normally in a very long period of time, and the pulmonic valve, in case it gets affected, it can still be treated with a melody valve, meaning with a transcatheter valve, and normally is not the main reason for which the patient needs a reoperation.
Now, if I may, Liana, the autograft rarely calcifies. And the technique of the operation is fundamental, and that's why Dr. Amodio said that it has to be performed by a team that has experience in this type of doing this type of operation. And we, the important thing is blood pressure control, and as a consequence, the ideal patient has to be a patient that is fully reliable, that will take the medications and be obsessive about controlling the blood pressure over the 12 months after the operation. And we put all those patients on naproxen, 250 milligrams BID, to decrease the inflammatory process on both valves, but mostly on the pulmonic homograft, which is the donated graft, even though it's decellularized.
Mm-hmm. This patient had open heart surgery in 2020, aortic valve replacement bioprosthesis. Does the procedure have a limited lifespan before it needs replacement again? And I was listening closely to Dr. Amodio talking about 10-year reoperations, 80%, et cetera. So what do we say to this patient?
So it depends on the age of the patient, depends on the size of the valve, depends on the type of valve. So the younger you are, and that's what the graphs that Dr. Amodio showed emphasize, is if you're under 55, your valve is much more likely to fail early because your life expectancy is longer, because your level of activity is higher, and that tends, and younger patients have been shown to calcify valves sooner or faster. As a consequence, If you're under 55, your valve would likely, a bioprosthesis, most bioprosthesis will likely last around 12 years. Some will get to 15 years, and some occasionally will get up to 18 years. But we keep, as surgeons, we keep wishfully thinking or hoping that a bioprosthesis will come along that will last 20 years. Yeah. We don't have such a thing. The only one we have is the Ross procedure. And that's the reason why we're concentrating on that in patients with aortic stenosis. And in patients with aortic insufficiency, repairing the patient's own valve. That is the most durable option by far. But to answer the question of the bioprosthesis, approximately 12 years. And the advantage of having had a surgical aortic valve replacement is that now the option of a transcatheter aortic valve replacement inside that valve is a very real and good one. Because then if you get to the end of life of that bioprosthesis, get a valve in valve, and then that valve in valve fails, you can still do a second surgery to replace that valve and start that process again.
Yeah, this goes way beyond hip replacement prostheses and knee replacements. This is the heart. So obviously your goal as the experts that you are is that the longest lasting possible. So maybe mechanical versus biological, is that where we're headed? Bionic?
Well, Dr. Amodio, you wanna address that one?
I mean, of course, if they are going to invent a mechanical valve that will last forever, that doesn't require any kind of anticoagulation, that doesn't require, that's the ideal maybe valve. We're still working hard to get it. So at the moment, as I show you from the studies, putting a prosthesis in will kind of change your life, no matter what we do. Because it's not only the risk of the valve failing, there are risk of having endocarditis, there are risk of having need of pacemakers, there are risk of, you know, the valve degenerating because it creates calcium under the valve, the so-called pannus. So there are multiple other reasons for which you might need a reintervention. So we cannot tailor on the patient. If the patient has a valve that can be saved, whether this is his mitral valve, tricuspid valve, or aortic valve, we'll try to save it. We'll try to put on our techniques to save your valve and not give you a prosthesis. And then when we choose a prosthesis, we'll talk together in clinic. We'll see what's your lifestyle, what's your work, and what are what kind of quality of life you're having, and how can the operation can bring you back to that. Okay, yeah. Whether it is going to be good one or the other.
Yeah, I was going to ask Dr. Umania, you know, we've talked a lot about aortic surgery, but you mentioned you're the only mitral valve center of excellence. Could you speak a little bit on mitral valve surgeries then and where we are in the 21st century at this point?
So, as I said, the mitral valve is the incidence of mitral valve insufficiency is much higher than people believe. And not as many surgeons or centers in the US and the world repair the valve routinely as we do. And mitral valve repair, as I mentioned several times, is the standard of care. It is the only operation that on the mitral valve restores the patient's life expectancy. And when you do, as we do, more than 50 mitral valve repairs a year with a mortality of less than 1% and a success rate greater than 98% in terms of risk of reoperation or incidence of more than mild mitral regurgitation on follow-up, then you become a mitral valve repair center of excellence. Mm-hmm. And that is a designation that we proudly hold and that we plan to maintain to be able to offer that to our patients.
And as a co-inventor of the mitral clip, I guess you've taken us a step beyond.
As a co-inventor of the mitral clip, I'm a great fan of minimally invasive mitral valve repair. I think the mitral clip has a clear place in the spectrum of the treatment of mitral valve disease, and certainly is a great option in patients that are not operable, that are too high risk candidates, or patients who have something called dilated cardiomyopathy, meaning a heart that has dilated, and as a consequence, the valve doesn't come together as well anymore. That's when the MitraClip becomes a wonderful option. In patients who are young, who have a mitral valve prolapse, the ideal intervention is a minimally invasive mitral valve repair. And again, it sounds daunting, but the reality is patients come in the day of the operation. They will be in the intensive care unit one night and they go home 3 days later. And they can be back to driving and doing their normal activities 2 to 3 weeks after the operation with a normal heart and normal valve. So it's really a wonderful operation, and one that when it's done by the right team at the right institution will have outstanding results long term.
The other dazzling thing that you talked about, I think it was Dr. Amodio, the hybrid rooms that you're creating. That is way out there, way advanced. Talk to us about that. We saw a picture that you put up, an image of it.
Yeah, so an hybrid room is a surgical room that also has the capacity of being or having all the feature of a cath lab or of a lab where there is a radiology bed that can help us in doing endovascular procedures. And this is also very useful when we do complex open procedures or when we open our doors to type A dissection emergencies, where the whole aorta is involved and then can be a malperfusion of organs that can go way beyond the heart. So in a hybrid room, we'll be able to address it tempestively before it gets to a point that creates an organ damage. But the hybrid room is also useful when we do arch surgery or when we do mitral valve surgery, because it's a room that is more equipped than a standard room in order to do this complex operation as more technology and can lead us to address these cases more effectively.
I guess I have to give a shout out to the patient calling us from Scotland. He's 64 years old, and his MRI showed bicuspid aorta severely narrowed and dilation of thoracic aorta. He's awaiting an angiogram. What surgical options is he facing?
So we should see the numbers, but exactly what we said, a 64 severely narrowed valve and dilation of the thoracic aorta, we need to see whether it involves the root as well. Probably it's going to be either an AVR, aortic valve replacement and an ascending valve replacement, or a root replacement. Depending on his angiogram, we need to check his coronaries, because at 64 we gotta see how his coronaries are doing and whether he needs bypass surgery as well.
But under 65 for a patient in perfect condition with a stenotic bicuspid aortic valve, that is exactly the type of patient that we can offer a ROS for. And in a 64-year-old, that will be the last operation that patient will ever have. And I think that's important to bear in mind, because now that goes back to the question you asked about the mechanical valve, because of more durability. The problem with the mechanical valve is that depending on the lifestyle of the patient, anticoagulation or Coumadin or blood thinners can be a disease in and of itself, right? If you're a skydiver, you can't take anticoagulation. You will die from a fall, right? So it's tricky, and patients who do not want to ever take anticoagulation, the ROS procedure is the perfect operation, and we can do them, and we can do that operation. Our cutoff is at 60, but really, when you talk at 60 as chronological age, you're not taking into consideration physiological age, and it's really not how many years you have on you. It's really the what does your body look like? Are you really 65, or are you one of those very active, strong 65-year-olds who really look 55 and act as a 55? So it's a physiological age that matters the most. And of course, this is a conversation. Shared decision making is the other part that I failed to mention as part of that heart team. The heart team, the patient connects into that heart team and makes it's a crucial portion or part of the decision making. We have to all come together and together with the patient decide what is the best option, what the patient would best like for him or herself.
Yeah. So the gentleman from Scotland will probably call your consultation lines and to bring them up. We're getting to the end of the program, but one of the things that occurs to me is all of this valve disease and all of these issues, is it a normal aging process? Is it lifestyle? Is it congenital? What's the bag here of why we are where we are with so many people suffering from it?
It's a combination of all of the above. Mitral valve prolapse and bicuspid aortic valvulopathy are congenital and hereditary. Dr. Amodio mentioned that bicuspid aortic valve is a very common congenital heart defect. It is the most common congenital heart defect. What Dr. Amodio didn't mention, because he's too modest, is that he, amongst other things, is an adult congenital heart disease specialist and surgeon. So this is right up his alley. But 1 to 2% of the general population will have a bicuspid aortic valve, meaning whenever you're in a room with another 99 people, there's 1 or 2 people that have bicuspid aortic valve. And mitral valve prolapse. I was talking to a referring cardiologist this morning who sent me 5 cousins for mitral valve repair with exactly the same lesions. One of them I operated on this morning. And so it is a hereditary disease. Now, aortic stenosis is a degenerative condition. And that's the reason why it spikes after 65 years of age. It's just, simply the heart beating, incessantly over 65 years, it will calcify. And of course, there's an underlying inflammatory issue. There's cholesterol, triglycerides, and genetics, and lifestyle. Of course, lifestyle makes a big difference and impacts any and all of these diseases.
Yeah. Some things we can help and some we cannot. We're born with. But gentlemen, you were both stellar tonight. If you want to say, we have 3 minutes left. Any concluding remarks for a minute or so? We are so grateful for the privilege of your time tonight.
I can only thank you, Ileana, for this opportunity and the interest. I've tried to answer as many questions as I can, but there are way too many, and I don't type very fast. I can operate but not type. It's been a real pleasure. I hope it's been informative, and I hope we've been able to highlight what is bringing to South Florida and how we're trying to change the cardiac surgical and cardiovascular medicine universe in the region.
Yeah.
Dr. Almudio?
Yeah, we are very grateful, and I think we're not trying only to fix your heart, but to give you the best quality of life long term, the best solution long term. Not only looking at the moment at the surgery, but looking at the individual as a whole. So this is at least our main goal.
That's a perfect concluding statement, because it has to be a holistic approach, and you're right.
Absolutely.
And we have to age gracefully and with quality. If not, what's the point? Thank you both very much for being with us tonight. Thank you to the audience that was smart and interactive, and the program's come to an end. But as I said before, there is the information for the cardiac surgery team to schedule an appointment. Number on your screen, 305-689-2784. Go online, uhealthmiami.org/heart surgery, or go ahead and shoot the QR code there on your screen so that you can get to it even faster. We ask for you to fill out your survey so you can give us feedback if you liked it, if you want other topics. And gentlemen, good night. And everyone out there, stay well and healthy. Have a great night, everyone.
Good
Thank
night.
you.
Thank you.
Good night.